Welcome back to Uncovering Bailey in Love with Snazzy Surgeon. Today we're going to go on another deep dive, a really practical one, I think, into a kind of tough area we all deal with,
Sure.
those non-lactational breast inflammations that pop up sometimes, not during breastfeeding.
Right, right. These can be tricky cases to sort out.
Yeah, and we're going to really focus on two big ones: the periductal mastitis and the idiopathic granulomatous mastitis, that IgM.
Yeah, and make sure we don't miss, TB, which is
Oh, yeah,
always a concern.
always in the back of our mind. So I think for anyone listening who's maybe had a few cases that left them scratching their heads, I think this deep dive will be really helpful to kind of have a better way to approach these patients. So let's just dive right in,
Yeah.
starting with that periductal mastitis. Um, when I think about those cases, it's always those patients who've come in and, they haven't breastfed for a long time. It's been, like 6 months or more,
Right.
right?
Yeah, at least 6 months since they stopped breastfeeding. That's usually the first thing that makes you think, this might be something different.
Exactly, exactly.
Now, the problem we're dealing with here is, this chronic inflammation, and it's really centered around those major milk ducts.
Hmm.
Figuring out the exact cause, though, can be a bit of a head scratcher. But we often think about the possibility of an autoimmune component.
Right.
And this is something we can't stress enough to our patients, the link with smoking. I mean, it really is a key piece of their history to get every time.
Every time. And it's fascinating how these cases tend to progress. They often start as like, an inflammatory mass right under the areola. And then if we don't catch it early enough, what happens?
Well, a lot of times we see an abscess forming right there, just beneath the areola. And it's actually pretty interesting when you think about the anatomy. The areolar muscles are thick. They're kind of arranged in a way that prevents the pus from just bursting right through the areola. So what happens instead is the pus kind of tracks outwards, towards the edge of the areola, and that's how you get those really annoying mammary duct fistulas.
Yeah, those fistulas, they
Yeah.
can be a real pain to deal with. And
Yeah.
speaking of pain, I'm sure we've all seen those cases where you feel that firm mass under the areola and you immediately think, oh no, could this be carcinoma?
Oh, absolutely. I mean, it's that classic presentation that always makes you stop and think. You have to be really thorough with your exam, with the imaging, to make sure you're not missing something more serious.
Right, right. And of course, that fibrosis that happens around those major ducts can lead to some pretty characteristic findings when you examine the patient.
Yeah, the physical exam can give you a lot of clues. So, what kind of things should make us suspect periductal mastitis when we're, talking to the patient and examining them?
Well, first off, that pain, that central breast pain that's not related to their cycle, it's not cyclical, that's a big red flag.
Hmm.
And then, of course, if they have pus discharge from the nipple spontaneously or if they express it themselves, that's classic.
Right.
And then obviously, if you can feel that tender mass right under the areola, and in those more advanced cases, you might even see the opening of the fistula.
Exactly. Now, when you're palpating, feeling for that tender, firm lump, or even if it's fluctuant, like an abscess right there in the subareolar area, that should definitely make you think periductal mastitis. But don't forget to actually feel along the major ducts themselves. Gently palpate them. A lot of times you can feel them as thickened, tender cords kind of running towards the nipple. And then there's that classic nipple retraction, that transverse slit-like retraction. It's what we call the fish mouth appearance. It's almost a hallmark of this condition.
Yeah, the fish mouth appearance. For those who haven't seen it, it's like, a narrow horizontal slit right across the nipple. Very distinctive. So when we have these patients coming into clinic, what are the key investigations we do to really pin down the diagnosis?
Well, ultrasound is incredibly helpful in these cases. You can actually see those thickened major ducts, and you can see any inflammation or fluid collections around them, which would suggest an abscess.
Mhm.
But to really make the diagnosis, like with so many breast problems, you need tissue. So we do an ultrasound-guided core biopsy of any mass we find. That way we can get a definitive diagnosis from the pathologist.
And what about sending those samples for microbiology? I mean, given the inflammation and the pus, that seems pretty important.
Absolutely. Any discharge from the nipple, if it's purulent, we always send that for culture and sensitivity. You'd be surprised at the variety of bugs we find. You've got your staph, your enterococcus, anaerobic streep, even bacteroids sometimes. And this is really important, especially in certain patient groups. We have to always think about TB. So sending that pus or even a tissue sample for a gen expert MTB or IHAF test is crucial to rule out TB early on.
Yeah, being able to rule out TB quickly is really important. So let's talk about management. Once we know it's periductal mastitis, how do we usually treat it?
Well, for a lot of patients, a conservative approach works really well. We give them a course of broad spectrum antibiotics to cover the bacteria, and we often do a needle aspiration of any abscesses to relieve the pressure and get rid of the infected fluid. And honestly, this works for a lot of cases.
But we both know that some cases are a bit more stubborn, or they lead to complications like those pesky fistulas. So what are our surgical options when conservative management just isn't enough?
So for those subareolar abscesses that just don't go away, or if the patient's getting sick, they're septic, or those really persistent fistulas that just won't heal with antibiotics and aspiration, well, then we have to think about surgery. The standard operation is a major milk duct excision. Basically, we remove about 1.5 to 2 centimeters of the duct right under the nipple. By taking out those chronically inflamed ducts and the source of the fistula, we can often get rid of the problem for good. And this is something we really have to hammer home to our patients. Quitting smoking is absolutely critical to prevent it from coming back.
Couldn't agree more. That smoking cessation message is so important.
Mm.
So now let's switch gears a bit and talk about another condition that can be really challenging. Idiopathic granulomatous mastitis, or IgM for short. This is one of those conditions where the lack of a known cause can really make diagnosis tricky.
Absolutely. IgM is benign, it's self-limiting, but because we don't really know what causes it, it can be a bit tougher to manage. We typically see this in younger women who have had children, usually within a few years of pregnancy. And, there's this possible link with Corynebacterium croppenstevii, which is something to keep in mind, but we're still not entirely sure what role it plays in causing the condition.
So how does IgM usually present? I mean, it seems like it can manifest in quite a few different ways.
You're right. It can present with one or more inflammatory masses, either in the center of the breast, around the areola, or off to the side. And just like periductal mastitis, those masses can turn into abscesses. But we also have to watch out for other presentations, like skin ulceration, nipple retraction, the formation of sinus tracts, even that peau d'orange appearance that can mimic breast cancer, and sometimes the lymph nodes under the arm can be enlarged. It can really look like cancer, which is why getting the diagnosis right is so important.
So given that it can mimic cancer so closely, how do we make sure we're diagnosing IgM correctly?
The most important thing is to get a biopsy. We do a core needle biopsy of any mass we find. And what we're looking for under the microscope is this characteristic pattern of non-caseating granulomas surrounded by chronic inflammation. And it's also important to send any tissue or fluid we get to the lab. We do a gram stain and culture to look for bacteria, AFB stain and culture to rule out TB, and fungal stains and cultures as well. We want to cover all our bases.
And what other conditions do we need to consider when we're thinking about IgM? What else could it be?
So our differential diagnosis includes TB, obviously, because of the granulomas.
Hmm.
But we also think about other things that can cause granulomatous reactions in the breast, like foreign body reactions. And then there are systemic diseases like sarcoidosis that we have to keep in mind. It's really important to get a good history from the patient and to do the right tests to figure out what we're dealing with.
Okay, so let's move on to management. We know IgM is supposed to be self-limiting, but that doesn't always mean we just sit back and watch, right?
Right. If the patient's having symptoms or if there are signs of infection, then we'll definitely treat them. We use NSAIDs for pain, antibiotics for any bacterial infection, and sometimes we have to drain an abscess. This can be enough to help them feel better. But, and here's a really important point, especially in areas where TB is common, we shouldn't just start TB treatment without knowing for sure. We need to have evidence from imaging, biopsy, or those lab tests, including that Gen-Esperity test, before jumping to conclusions.
Makes sense. So what about those patients who have IgM that just doesn't seem to get better, or it's actually getting worse even with the initial treatment? What are our options then?
Well, for those more persistent or progressive cases, corticosteroids can be really helpful. We can give them prednisolone by mouth or sometimes even a topical steroid, and that can often get the inflammation under control. In some cases, especially if it's really severe or not responding well, we might also consider adding methotrexate. It's an immunosuppressant that can help calm down the immune system and maybe allow us to use a lower dose of steroids. And then, similar to periductal mastitis, if we have a fistula that just won't go away, we might have to surgically remove the affected milk ducts. And in some cases, if there's a chronic abscess that keeps coming back, we might even have to remove that surgically.
So it seems like managing these non-lactational breast inflammations really requires a combination of a sharp clinical eye, knowing when to order the right tests, and a deep understanding of how these conditions can present. And I think it's really important to remember that periductal mastitis and IgM can look quite different, and we always have to think about the possibility of TB. Doing all of this will help us manage these patients effectively and avoid missing the right diagnosis. Hopefully, this deep dive has been helpful for everyone listening.
Yeah, the key takeaway here is to always keep an open mind, to do those biopsies and imaging studies when you need to, and to treat each patient based on their individual situation and what the pathology shows.
Thank you for listening to our podcast. See you in the next episode.